Thank you, Fatima. So today's three topics are infectious diseases, cardiology, and neurology. And by no means they are like separate individually. They are like a continuum of each other. So let's see. A 70-year-old gentleman comes to endocrine clinic with the complaints of increasing fatigue. So as I always tell all the students that in the question, there are four basics of attempting a question. Four basics. One is, do you get the patient profile? So they would try to build up a patient. They will try to build up a case. And once that case is built up, they will ask you a question. So do you get the patient's profile? That's the first thing. And in the profile, you will need to see age, because certain diseases are more common in certain age groups. And then they would tell you in which clinic the patient presented. That will give you a clue as to what they are going to ask, like endocrine clinic. So this is directly given up, endocrine clinic, that this patient has some endocrine problem and is following up with an endocrinologist. So that means either it's an endocrine question which is going to be asked, or it is a question which is to be stemmed out from an endocrinology problem like complication of diabetes. So he's a 70-year-old gentleman who's coming to endocrine clinic with complaints of increasing fatigue. So increasing fatigue can be because of anemia, increasing fatigue can be because of congestive cardiac failure, or it can be because of low cardiac output syndrome, 𝑭𝒂𝒓𝒛. When the left ventricular failure is there and it is not causing congestive symptoms, sometimes it can cause forward outflow symptoms. So they can also contribute to fatigue. Or uremia can also contribute to fatigue in a patient of diabetes. Then fatigue can also be a dysautonomia. That means autonomic dysfunction that occurs as a part of neuropathy in diabetes. Okay, so patient has come to you with increasing fatigue, poor healing of his left leg ulcer for long duration. So that means there is an evidence of peripheral vascular disease, which is an integral part of diabetes, uncontrolled diabetes. Recent investigations showed that the patient has uncontrolled diabetes. Can any one of you define uncontrolled diabetes by just one definition, which is NICE guidelines approved definition? Uncontrolled diabetes. Anyone?
By HbA1c.
So when HbA1c is more than 8%.
More than 8.
Okay. So whenever the HbA1c is more than 8%, we call this condition diabetes as uncontrolled diabetes. Fine. So given that the patient has uncontrolled diabetes, this doesn't mean that examiner is feeling that the patient has uncontrolled diabetes. It means they are following the definition. So this patient of this uncontrolled diabetes is a definition itself with signs of local infections of the ulcer site. So diabetic foot is there with uncontrolled diabetes. His surgeon advised him for a good diabetic control one. On detailed discussion, it is revealed that the patient is also suffering from chronic heart failure. So see, one of our differentials has come true, that is congestive cardiac failure or low cardiac output syndrome. Both of them are manifestations of chronic heart failure and is currently well controlled, not well controlled, but controlled on carvedilol, which is a beta blocker, ramipril, which is an ACE inhibitor, and torsemide, which is a diuretic. Among the following hypoglycemic agents, which one of the following should be avoided in this person's glycemic control? So this means that they are asking for the correlation and association of oral hypoglycemics with cardiovascular system. Okay, the effect of OHA on cardiovascular system. Okay, tell me which are the favorable drugs for cardiovascular system which are anti-diabetics. Anyone?
The metformin.
Okay, metformin.
And
this is So when you say dapagliflozin, you mean
As
to say
SGLT2 inhibitors.
Yes.
SGLT2.
So now they are even approved for patients who do not
Yeah,
have diabetes.
They are
So
pillars for
now,
heart failure treatment.
yes.
Yeah.
So after the MRCP trial, they are approved for patients who do not have diabetes and they are having heart failure. So it's now a standard management of heart failure with reduced ejection fraction. It is one of the pillars of heart failure with reduced ejection fractions management. Okay.
Yes, sir.
So which are the options that we have here? Can you just read out loud for me?
Glipizide, dapagliflozin, metformin, acarbose, pioglitazone.
Okay. So what is the effect of glipizide on heart failure?
Maybe, sir, this will be the answer for this question, because if it can cause hypoglycemia, and if it is given with beta blocker, so that hypoglycemic symptoms will not be shown.
Okay. All right. So that is one approach, one way of thinking. But these drugs are the cornerstone of diabetes management as far as the risk profiling is concerned. So anyways, patient needs a good diabetic control. Out of these drugs, which drug has the maximum effect on the HbA1c is sulfonylureas. So glipizide definitely will be required for the patient. So it is not that we would want to omit this drug. This is the drug which is required. Why? Because we need good diabetic control. Either we give it with sulfonylureas or we use insulin for this patient. Okay.
Yes, sir.
Second is SGLT2. We already discussed they are the beneficial drugs. Again,
That it's important.
Acarbose is cardio neutral.
Okay.
Okay. Acarbose is cardio neutral. And then what do we have? Other option is pioglitazone. So the problem with pioglitazone is that it causes fluid retention.
Beta
So
blocker.
would you like to give some drug which causes on one side we are giving torsemide and on other side we are giving pioglitazone. So that means this will lead to worsening of heart failure, or
Heart failure.
the controlled heart failure may become uncontrolled heart failure. Okay.
Yeah.
So there have been several trials on pioglitazone, and many of them were stopped prematurely because the mortality increased, the hospitalizations increased in cases of patients with heart failure. Okay. So the answer ethically should be pioglitazone. Baki, if the cardiorenal syndrome has set in, let us say they did not purposely mention the creatinine of this patient. If cardiorenal syndrome sets in, that means CKD element starts to enter, then sulfonylureas will also need to be decreased. Glipizide is fine because it is short acting, can be repeated again. Dapagliflozin cannot be given if creatinine is more than 2.1. Although now trials are coming that you can give it up to the creat clearance of 15 and above. So that means even up to stage 4, stage 5 you can give. But I would leave it for the domain of a nephrologist to put it. Metformin will be contraindicated if patient has CKD. Acarbose is a safe drug because it is excreted unchanged in the stool. Pioglitazone, again, if there is cardiorenal, you will not give. So in case this patient, this gentleman also has kidney disease, the only safe drug remains acarbose. And short-acting sulfonylureas like glipizide. If there was glimepiride mentioned here, then it will be contraindicated in case of CKD. Why? Because its effect is 24 to 48 hours. Hence, higher incidence of hypoglycemia will occur, as the gentleman already said, but that will be an indication for renal involvement. Okay? All right?
Yes, sir.
So the answer over here is E or A then.
Okay. So the answer that we have here is Answer is E. So answer is pioglitazone. So it can cause retention of fluid. Hence, in patients of heart failure, hyperdynamic circulatory state, they may worsen the cardiovascular physiology. Other agents like acarbose, glipizide, dapagliflozin, metformin can be used with pre-existing heart failure. During critical state, however, all the oral hypoglycemic agents should be avoided. Okay? So you should use insulins there. If the patient is deteriorated for any reason, you should be using other agents than oral hypoglycemic agents. All right. So first question, okay, done. Any doubts?
No, sir.
All right. So now second question. So it was from cardioendocrinology. So this is an upcoming branch, which is cardioendocrinology, because endocrinology is a good branch, but usually the endocrinologist tends to lose his patients to other branches. Because once the complication sets in, if CKD sets in, the nephrologist takes away the patient. When the cardiology sets in, cardiologist takes away the patient. So cardioendocrinology is that endocrinologists now take care of the cardiovascular function along with the endocrinology part they are managing for their own patients. Okay. So because it is an upcoming branch, you will see a lot of patients being asked in questions from both cardiology and endocrinology perspective combined together. Okay. So whenever you see an endocrinology question, try to focus on which cardiovascular diseases can present along with, and then be prepared for drug interactions. All right. So a 65-year-old lady, she has come to the cardiology clinic. She's old. She's coming to cardiology clinic with history of recurrent episodes of peripheral vascular disease. Ye kya baat hui? History of recurrent episodes of peripheral vascular disease. It cannot be mentioned on the patient's forehead, no? So she might have claudication. Yeah? Claudication is pain in the legs. Or bluishness of cold feet, bluish discoloration of the toes. So all these things can be put in peripheral vascular disease. For last 2 years, she had undergone embolectomy surgery previously as well for her vascular disease. On detailed discussion, she revealed that she is allergic to aspirin. She had no other history of embolic manifestations like stroke or TIA. Apart from peripheral vascular disease, her ECG also shows normal rhythm. Echo shows a good functional activity of heart. Among the following drugs, which one has the reducing capacity of vaso-occlusive events? So now we have a drug which has been proven to decrease the vaso-occlusive events. Now, vaso-occlusive events could be venous events and could be arterial events. Okay. Now, my question to you is, which are the drugs approved for arterial thrombosis and which are the drugs approved for venous thrombosis, and why they are different? Anyone?
Arterial thrombosis, aspirin.
Okay. Can you be a little more generic than aspirin? Generic as in, I need a better answer than that.
So for venous thrombosis, for venous thrombotic diseases, we usually use anticoagulants, and in nowadays ages we use NOACs, etc. Because these they tend to form clots, and we need to make sure that either they are clot busters or clot dissolving agents, and they prevent formation of further clots in future. While when there is any arterial occlusive diseases, it's either a plaque or say emboli, or it is something which is we need to sort of create sort of so that's usually an antiplatelet or
Yes.
I hope I'm
So
getting on the
the
right
more
track.
generic statement here would be, yeah. So arterial thrombosis, you have to understand that usually, as you said, it's a plaque rupture. So the pathology is different. So arterial thrombosis, you use antiplatelets, and antiplatelets are aspirin, as the doctor said, and dipyridamole, clopidogrel, ticagrelor. So these are GP2B3A inhibitors. So these are the drugs that can be used for arterial thrombosis. And if the thrombus has formed, you can even go for a thrombolysis. So thrombolytic agents would be the next in the line. Now, the another thing is, in the venous thrombosis, the clots are differently formed. So they require anticoagulants. So anticoagulants are basically divided into two. One are the vitamin K antagonists like warfarin, like acetrom, that is coumarin derivatives. And then there are, as you said, NOACs. So NOACs are also anticoagulants. So these NOACs are, you can remember NOACs. You can remember the NOACs by a very simple formula, that NOACs can have X in them or D in them. X means factor 10 inhibitors. So they are 𝒃𝒐𝒏𝒛, rivaroxaban, and of course edoxaban. This D is dabigatran. Dabi means direct. D means direct thrombin inhibitor. Okay. So vitamin K antagonists and NOACs, these are oral agents. If I have to give injectable, then the answer would be heparin or low molecular weight heparin. So these are the veno-occlusive diseases preventing drugs. Now, there is one thrombus, or you can say thrombo-occlusive event, which takes place in a disease known as atrial fibrillation. In atrial fibrillation, the clots are formed in the left atria, okay, or specifically in left auricle. So in left auricle, which is supposedly the venous side of heart, hence the drugs are again VKAs or heparins or NOACs. So to prevent thrombo-occlusive events in atrial fibrillation, the drugs are this. So the criteria is that it has to be a avalvular atrial fibrillation. If it is a valvular atrial fibrillation, then only VKAs can be used, or heparin can be used. NOACs are not approved as of now for avalvular, I mean where mitral stenosis or rheumatic heart disease is not the culprit. So now we have a arterial.
So sorry, could you repeat
question.
that? So so with avalvular, when it originates in the left auricle, it's vitamin K antagonist, and what else did you say?
Heparin.
Heparin. And below that?
And NOACs.
And NOACs. And below that?
If atrial fibrillation is due to rheumatic heart disease or valvular heart disease, then you cannot give NOACs as of now. Let us say somebody has a atrial fibrillation with prosthetic mitral valve. That means mitral valve repair or mitral valve replacement. So prosthetic mitral valve, even then you cannot use NOACs. The drugs that you have to use is VKAs. Okay. So because left ventricle, left atrium is basically the venous side of heart. So why I'm telling you this is to remember that venous drugs are VKAs and all the attendant like NOACs and heparin. Whereas arterial thrombosis, A is antiplatelet agents.
Okay, that's easy.
Or you can remember LT. Yeah, LT-plase. LT-plase is thrombolytic agent.
LT-plase.
Okay, you get the answer now. So on the venous side of things, you need to add VKAs. On arterial side of things, you need to add antiplatelets or LT-place, that is thrombolysis, in case it happens. That is why coronary artery disease, it is an artery disease. You give aspirin, you give ticagrelor, you give dipyridamole, you give clopidogrel, you give prasugrel. So these are the drugs, antiplatelets. Or you thrombolize the patient with streptokinase, urokinase, LT-place, TPA, and all those things. Okay.